Zach, would this normally be live on the Facebook CML UK page, or just live if they go onto your page?
It's just live from Leukemia Care. Do you want to share it in the CML page?
I'm thinking I'll put a note on the CML page.
Okay, we are now live on Facebook as well. So this is now being recorded on Facebook. Let's see. Right, let me share my screen.
Zach, do you want us to introduce ourselves quickly before you do your slides, or would you like to do that later, or how do you want to do that?
I was going to introduce you, but as we're waiting, do you want to introduce? You know, go on. You do you want to introduce yourself? So, Steve, do you want to introduce yourself first?
So, hi everybody. I'm Steve O'Brien. I'm a consultant hematologist and a professor of hematology at the Freeman Hospital, which is where I'm sat at the moment in Newcastle. And I've specialised in CML for more years than I care to remember, and I've run the national trial. So hopefully this next hour will be used from a clinical or clinician's perspective for you as well. Nigel, over to you.
Yeah, hi, Nigel Deekes. CML patient diagnosed, just coming up 10 years. Obviously helped run the Facebook UK group and also the CML support group website as well. As I say, hopefully I'm known to a few people here, and welcome on board. Hope this is very helpful. Before we start, Zach, I'm just on the Leukemia Care website. Whereabouts can I find the link, please, so I can share it on Facebook?
It's on Leukemia Care's Facebook page.
Ah, okay. Sorry, far away.
That's all right. I'm just trying to work out technical difficulties. I'm trying to, it's doing full screen, and I'm trying to find the actual Zoom chat. But so hopefully I don't ruin the sharing, so the slideshow, because I need to find.
Zach, would it help you if I put the screens on, if I share the slides and you look to the participant list? I can do that, or you can multitask if you wish.
Don't worry, I'll multitask. I'll do that, and then I'll get it sorted in the background whilst once I've done the introduction bit, whilst we get to the Q&A. Right, okay. It's 5 minutes past 10, so we're giving people plenty of time to join. I'll just repeat the intro bit for anybody who wasn't here when we first started. So I'm Zach Pemberton-Whiteley. I'm Patient Advocacy Director at Leukemia Care. You'll have just heard Steve, who's a consultant hematologist specialising in CML, and Nigel, who's a CML patient. They're going to give us a clinical and patient perspective on CML and coronavirus. We can't answer any individual clinical questions. We're not going to make Steve do that over Zoom. But we can answer general questions relating to CML and what patients should be doing. This is specifically aimed for UK patients. So if anyone has joined from abroad, you're welcome to join, but the guidance we're going to be giving is specific to the UK. We're going to be asking questions throughout this. So if you've got any questions, please do post them on Facebook as a comment or in the chat function here on Zoom. And I'm going to start by giving a short overview of what the government guidance is generally for cancer patients and for shielding, and then we'll go into the CML specific nature of this. Okay. So hopefully everyone will have seen that the government guidance from Public Health England is that people with cancers of the blood or bone marrow, such as leukemia, lymphoma, or myeloma, who are at any stage of treatment, are in the highly clinically vulnerable category. They've also included anybody who's currently receiving targeted cancer treatments, which can affect the immune system. We've been in constant conversations with NHS England around this, and they do very much say this is taking a cautious approach. They are making sure everybody who could potentially be in this highly vulnerable category falls within it. And the reason they're doing that is because they really don't know. This is a new situation that's never affected anybody before, and they're looking at those that they would consider to be at the most risk should they contract coronavirus. anybody who falls in this highly clinically vulnerable category, they're asking to shield. So shielding, just to be really clear on this, because the terms shielding, social distancing have all been thrown around. They're all very new to us. And hopefully we all know what they mean, but just to be clear. So shielding means don't leave the home at all. Don't leave the home even for exercise. Don't leave the home to do shopping. Don't leave the home to go to work. The only exception from the government here is for medical appointments. And this specifically differentiates shielding, which is what the extremely vulnerable patients are being asked to do, in comparison to socially distancing and the lockdown situation, which is what the general population is being asked to do, where there are these exceptions where you can go out. The guidance is for anyone that you live with who is still leaving the house. The government guidance at the moment is if they can socially distance as normal, then they can still leave the house. However, that requires them to also socially distance from you within the house as somebody who is vulnerable. So that means don't use shared spaces at the same times, clean between uses of those shared spaces if possible, use separate dish cloths, towels, and the guidance is to stay 2 meters apart at all times and to sleep separately wherever possible. Now, we'll get probably in the questions to whether or not that's feasible and what that maybe means for you. And how you're meant to know whether you are in the vulnerable category. The first is the government guidance. So that hopefully kind of gives you a heads up to begin with. But secondly, people should be receiving letters. We are aware there have been problems with these letters. There have been delays in them getting sent out. And many people who would consider themselves to fall within the government definition have still not yet received a letter. I'm sure we'll probably talk about what to do in that situation. But if you haven't received a letter, you can register yourself for support. You can register yourself as vulnerable if you think you fall within the definition. In England, there's a central online system where you can do this. And then also you can approach your local council. And the guidance for other parts of the UK is to contact your local council to find out how to do this. If you haven't received a letter and are worried about what to do, the general guidance is contact your haematologist and or your GP and find out what's going on. And if you're having issues, do please contact us at Leukaemia Care, see what there is that we can do to help, but also to let us know, because we're trying to understand how many patients are still affected by this so that we can raise the issue with NHS England and the Department for Health and Social Care. So the last slide from me is around treatment changes as a result. Doctors across the NHS are obviously looking at the risk-benefit analysis of every type of treatment, and this is generally for cancer. Urgent cancer treatment has still been maintained as a priority. That's something we're hearing constantly from NHS England, and particularly in the CML context, although I'm sure Steve can talk to this, where treatments are oral, then there's no need to attend hospital to receive your treatment. So that's where the balance comes in on an individual basis for some cancers, is the balance between going into hospital for treatment and not. So the balance is obviously slightly different in CML, and they are prioritizing cancer treatment as something that they want to go ahead with. So if you're hearing around appointments that your clinical team are still asking you to do, your clinical team are correct. Please do follow the advice you're receiving from them. So that's the overview of cancer generally from me. I'm going to turn to Steve, who's going to give a clinical perspective on CML and what it is that patients should be doing.
Thanks very much, Zach. I've just got two things to say as an opener, and then I think Nigel's going to make some comments, and then we'll spend most of the time, I think, doing Q&A. The first thing I'd say is that I'm not an expert on COVID-19, and I think at the moment, even the experts are not necessarily expert on COVID-19, because there's so much about this virus that we don't know because it's new. So I suspect many of you are wondering, whether you are more susceptible to this virus, either by virtue of the leukemia itself, by having CML, or by virtue of taking imatinib or another tyrosine kinase inhibitor. And I think the honest answer is nobody really knows for sure, including me. So I think that's an important point to state at the beginning. Many of the questions you might have, I'm not sure I know the answers to, but we can still discuss them. The second thing I'd say is just a very simple message, and I think it's really important at the moment that we all, as citizens, as patients, as healthcare providers, try and stick with simple principles and tough them out for a while. And as you will know, I suspect and as Zach has pointed out, the simple guidance from Public Health England is that essentially people with CML, whatever stage they're at, whatever treatment they're on, whether they're on or off treatment, fall into the group that they would call clinically extremely vulnerable and therefore should shield for at least 3 months. So I guess that's going to take us to the beginning of July. We may have some discussion about what happens if this period of preventative methods, whatever, carries on for more than 3 months, and we can discuss that. But I think I would emphasize that my position, what I'm saying to my patients here, and what I would do if I had CML myself, is to stick with the government guidance and to shield for 3 months. So those are my 2 simple messages. Lots we don't know about this condition, so much uncertainty, number 1, and number 2, I think I would toe the line, and that's what I'm encouraging my patients to do, and stick with the shielding principle. Nigel, over to you, perhaps.
Okay. Yeah, and really I would concur with what Steve's just said there. Basically, we do need to be being very careful and shielding as much as we possibly can. There are some people, me included, that makes it very difficult for, because in my own example, I run a business and I have staff that depend on me, therefore to shield properly and fully is a very difficult thing to do. And there are other people who are members of this group and out in the general public who have to go to work for whatever reason, be that they are key workers themselves, be it income, or be it that they have family that have to go out to work. So shielding in the absolute sense does become slightly more difficult. And I think that if you are not fully shielding, we need to be very careful when we go out. Personally, whilst I go out at an absolute minimum, I tend to pop into my office at sort of 7:30, 8 o'clock in the morning when there are less of the general public about. The office is closed, but it just means I'm not coming into contact with people. It's just trying, if you can't fully shield, to be as sensible and to shield as much as you possibly can would be the message I would give. Zach?
Yes, so thanks for that. Firstly, apologies for anyone who was seeing my screen. I was trying to get access to the meeting chat and sharing some of the questions we'd had through in advance, apparently. So we'll probably start with those. So Steve, a question for you to start. Yeah. What should people be doing as a CML patient if they do get symptoms of coronavirus? Should they be letting their hematology team know? Should they be doing anything different from the general population?
I think most, I mean, it's a tricky one to be absolutely sure of, because, you know, where do you draw the line? If you've got a runny nose and you just have a bit of a headache, do you go straight to hematology as an emergency? Or would you call 111? You know, I think you have to be weighing things in the balance as to what you think is appropriate. Most hematology patients will have access 24/7 to their service, so there's no harm in ringing up for advice if you have a connection with hematology at your local hospital. But I think it depends on the severity of your symptoms. If you've got the classic symptoms, which are a high fever and a cough, then I think you should probably get in touch. And I would encourage my patients to get in touch with our service. And then we can perhaps do an assessment over the phone. If they live miles away, we might ask them to go to their local hospital. If they're around the corner, we'd ask them to check into our hospital. One point to be clear on, though, if you are going to hospital with suspected COVID, you should be going into the normal access point for that service in your local hospital, not necessarily to the hematology ward, because of course we want to avoid spreading COVID around our own wards. So I think you should always feel free to contact your local specialist nurse or doctor, but if you do end up going to hospital, go into the usual route for that hospital, not to the hematology ward.
Excellent, thank you. So a lot of the questions that we've had in are in relation to blood tests. So we're getting contrasting advice here. So one in terms of So apologies, obviously Steve is dealing with individual clinical care at the moment as well, so thank you for taking an hour out to join us from this. But so the question was relation to blood tests. So two different questions. One, is it safe to go out for blood tests if you're being asked to come into the hospital by your clinical team to do it? And then also, other people are being told that their blood tests are cancelled, and is that safe to do?
So again, I think a bit of common sense is required. If you are due a blood test at a 3-month interval, for example, and that's coming up next week, and someone said, can you wait for 4 months rather than 3 months on this occasion? I think that's pretty reasonable. We've done a lot of that locally here, especially if you've been on treatment for many years and are very stable. You know, you could easily extend blood tests for a month, maybe even 2. I think going beyond 4 months would make me feel a little bit concerned, but a short delay would be reasonable. What we're doing here, and I suspect many other people on the call have experienced this, is I have my clinic this afternoon, but my clinic is this afternoon. There's my patients. That's what I'm going to be doing. They all came yesterday very quickly to the blood taking facility in outpatients, nipped in, had a blood test, went away straight away, weren't hanging around, and I'm phoning everybody. We have 0 patients come into the clinic this afternoon. So I would hope your local hospital would offer that. So yes, you should still have blood tests done, but if it's extended by a little bit, a month or so, I think that's reasonable, but it can't be extended forever.
And just to kind of ask a very specific question on that in relation to CML, if patients are worried about what will happen during this period, whether they will either kind of relapse from TFR or relapse whilst on treatment, what should they be doing? What should they be worried of doing if they think their leukemia may have come back?
I think it would be the usual standard of care, really. So there's no reason, of course, why at the moment that sort of event is any more or less likely to happen. But I think it comes back to the previous question about keeping a reasonable connection with your blood sampling. So I don't think people need to be overly concerned, because the progression rates and loss of relapse rates with certain patients with CML is very small. So it's a very low risk situation for most patients with CML generally. But I think if you can keep to, you know, a 3 or 4 monthly routine of blood testing, perhaps a bit more frequently, you've just recently stopped, then that would be fair and appropriate and reasonable. I guess one thing to add about that is the decision to stop treatment because of an excellent response, and Nigel might want to comment on this, is something that can be done at a fairly leisurely pace. You know, it's not urgent that you stop treatment now unless you have some major intolerance problems. So often the frequency of monitoring your blood, if you've stopped treatment today, is going to be more frequently than 3 months. It might be 1 month, for example. So if you're considering stopping treatment, I think now might not be the best time, because you couldn't as easily have that 1 monthly blood count that you might need, or PCR test, as you might be in normal circumstances. So it's a consideration if you are in that position, that fortunate position of facing treatment-free remission. You might want to delay stopping treatment until you know, at such time as blood tests are more readily available.
And I would absolutely agree with that. I think, you know, there is no danger in keeping on treatment for a longer period of time. If anything, it will actually help your chances of stopping successfully eventually. So I think a delay of a month, 2 months, 3 months, 6 months, as I say, doesn't cause any clinical damage and arguably would be potentially beneficial. The main thing is the ability to get in on a monthly basis, which I think is extremely important in the first 6 months of treatment-free remission, and potentially putting yourself at danger going into clinic month after month after month. I would agree, you know, it is worthwhile delaying that for a time.
So we're getting a few different questions coming in on the different platforms, kind of asking about the specificities between this. So on the one hand, we're telling people to shield, and on the other hand, we're telling people to go in for a blood test. How do you kind of rationalize that, Steve?
It's a question of balancing risk and benefit, isn't it? unless you have someone who can come to your home and take a blood sample, and I'm conscious there are some areas where those services are offered. We offer that to some of our patients. Then that's great. But maybe that person coming to your home to take a blood sample has been to 10 other homes that week, one of which may have a COVID patient in. So there's no guarantee, and that person's going to have to get close to you to do a blood sample. So, you've got to weigh things up, I think, and apply a bit of common sense. I wouldn't want my patients hanging around waiting for a blood sample for 2 hours in a clinic. And I don't want them hanging around in my clinic waiting to see me for an hour or two this afternoon, which is why we're doing it all by phone. But you have to weigh up the pros and cons. And if you've had a blood test 3 months ago and can wait a month, that's okay. But I think at some point you're going to have a blood count to make sure that your treatment delivery is safe and that it's effective. So I realize those two things slightly conflict with each other. You're shielding, but you have to go and get a blood test. But that's the reality of the situation. You can't go completely unmonitored whilst you're receiving treatment for CML.
I'd add to that as well that, if this does go on for 3 months, 6 months, 9 months, 12 months, which watching the news last night is very possible, and we'll talk about shielding in a moment for a prolonged period of time. You'd still need to go and have your PCR test, let alone a normal full blood count. We need to have a PCR test to ensure that there are no changes, that you're not becoming resistant, there aren't mutations taking place, etc. So from my personal point of view, I think the risk, in inverted commas, of unshielding to go to the hospital as long as you're in and out fairly quickly is something that has to be done.
Just something to add as well. I mean, we're hearing on the news today that we're going to get an expert position and a government position about whether we should all be wearing masks. You can see I'm not wearing a mask at the moment. I don't walk around the hospital wearing a mask, but I do when I go and see patients on a ward round, especially if they've got symptoms. I don't wear one at home. I don't wear one when I go to the shops. But I think if you, it's a simple thing, but if you needed to go to the hospital for a blood test, then get a mask. And plot one on. There's no downside to that particularly, and it would potentially, who knows, but potentially reduce the risk a little bit.
So one of the questions we're getting here is around treatment. I'm not aware of any, but Steve, are you aware of any treatment shortages in relation to any of the CML drugs at the moment?
I've not heard of any treatment shortages of anything. I mean, we've all heard about PPE shortages, etc. But in terms of any drugs I've had to deal with on wards when I've been on call recently, I've not heard a dicky bird about that. And I've certainly heard absolutely nothing at all of concerns about the provision of treatments for CML of any kind. So I think people can be reassured about that. If there was a problem, I think I would have heard about it. Nigel, I don't know if you've heard any more.
I haven't. I mean, I do speak to the manufacturers on a fairly regular basis. And the one thing that was said to me by a couple of them is that large provisions of stocks were made for Brexit. If you remember, Brexit happened a few months ago. And therefore there was a good supply of them available and in the country. So again, I haven't heard of any issues with that. And certainly a couple of months ago, there was a stockpile is maybe too strong, but a good supply of them.
Excellent, thank you. So we're getting other questions in relation to shielding from people who haven't received letters. So just to be really clear on this, Steve, CML patients who haven't yet received a letter, what should they be doing?
Assume it's an administrative oversight. I think the sending of letters was pretty good, but I've certainly had some of my patients who've not received a letter and they're no different to the next person who has received a letter. I think it's just that the system is not perfect. So I would absolutely not read into anything if you have CML. The fact that you have not received a letter, that does not mean that somebody thinks you are not at any greater risk than the average person. I think it's an oversight. So if you have CML and or you're on treatment for it, you should assume that you should have received a letter, because that's what the government, the Public Health England guidance states.
Thanks, Steve. And we've had a question in specifically about CML patients who've had a stem cell transplant. What would be the guidance for those patients? Obviously, this might vary depending on the time since transplant, but what would your advice be?
I think if you've had a transplant, especially recently for CML, there is no doubt in my mind that you are at significantly greater risk from infection. That's very clear cut with transplants. And if you have complications like graft versus host disease, if you've had to have steroid medication, for example, then you clearly are at greater risk of having all sorts of viral infections, including COVID, I think, in that situation. So if you've recently had a transplant, by recent I mean within the last year, I think you need to be particularly cautious. I think there's some suggestion, even longer term post-transplant, that you may have a degree of reduced immunity. Quite how long that lasts for is unclear. But even if you are a few years out from a transplant, I'd still be on the cautious side. But from what I've said so far, really that doesn't differ from if you're a CML patient without having had a transplant. I think shielding is appropriate whether or not you've had a transplant, but I just think you are definitely at slightly greater risk if you've had a transplant, particularly recently.
Thank you. And so one question we've had in is whether there's any evidence that CML patients are more likely to have severe COVID or more likely to die if they do get COVID.
Good question, and I'd really like to know the answer to that. But the answer is, I don't know. And I think the answer is nobody knows. If you look at, there's very few data that have come out of the China experience, for example, which I guess was the earliest and quite substantial about cancer patients in general. But there's no meaningful evidence really about the outcome of CML patients. So I think the most honest thing I can say is I don't know, and nobody knows.
And so just to kind of clarify then that in the context of shielding, these are people that we obviously are considering more vulnerable than normal. So this is really looking at the difference between evidence of high risk, and we have an absence of evidence saying that people aren't high risk. That's why we're taking the cautious approach of saying, in line with the government guidance, you should be shielding.
That's exactly right, Zach.
Okay. So we've got some questions in specifically here in relation to having telephone consultations where patients may actually not have had blood tests. What's the situation there?
For my patients, and I just showed you my clinic list this afternoon, there's not many where I'm doing that. Sometimes, you know, I'm looking after patients who live far away, so they may have had a blood count not at my hospital, but they've had something, you know, a distance away, a GP or have you. So I think having a phone conversation or phone consultation without a blood is of limited use really, because I think patients want the reassurance of knowing that they're okay in that consultation and whether or not they should be on the same dose of treatment, whether they should be changing, etc. So again, it harks back a little bit to what we were saying before, Zach. I think weighing up risk and benefit, I would absolutely stay away from clinics. You don't want to be sitting around a busy waiting room for an hour or two next to lots of other people. So if your hospital is not yet offering that facility, you are perfectly within your rights, I think, to ask for that. And I think the ideal model is nip into the hospital very quickly, maybe wear a mask, have your blood done, zip out very quickly, don't hang around. And then I typically follow up those patients maybe a week or two later, once we've had a chance for the PCR to get processed and I've got all the information to hand. And that's absolutely the norm now. I haven't seen a patient physically in the clinic for 3 or 4 weeks.
Can I just ask a question on that? Obviously, we're going in having blood tests and leaving telephone. What happens with the delivery of TKI? Again,
that varies. For some of our patients, and again, I think many people online will have this experience too, we have a home delivery service using various companies. That's changing a little bit now. So our local Lloyd's pharmacy will sometimes deliver to patients' homes or to a local pharmacy. We have some situations where a family member will go to the pharmacy a day or two later and pick up the packet, because it's very hard to avoid queuing in the pharmacy, which is just as bad as queuing or hanging around in a clinic. So if you can get your medicine delivered, that's fine. If not, maybe get a family member to go and get it. The trouble with the delivery at the moment is you can imagine the demands on delivery services for pharmacies are very considerable, and sometimes it's just not possible. So I generally advise patients when they're picking up their meds from the hospital to come in, have their blood go away, and then get a family member, if possible, to come in a few days later and hang around the pharmacy to get the pills for them.
And just for sort of clarification of that, a family member, I personally, if that was my situation, would be a family member that didn't live in the household, because that person is going to have to go to the hospital and stand in exactly the same queue to come home. Yep. So I think if possible, as I say, I know it's stating sort of the obvious, but don't get somebody who's living in your household. It needs to be part of your extended family that goes to the hospital to pick up the drugs.
Sounds very sensible.
So one question we are getting in is people receiving advice that's different from either their GP or from a haematologist. So the guidance we're hearing from you, Steve, is very clear. If you have CML, the government guidance is SHIELD. That's the guidance we've heard from the Hammersmith as well. But some people are hearing different things from their GP, particularly we're seeing in the comments, but also potentially from their haematology team. What would your kind of response be to that?
Well, we're all grown-ups. We can all listen to and take or ignore advice as we wish. As I said at the very beginning, I'm not an expert on this. I think there are a few genuine experts because we're all learning about this as it goes along. So I would restate my position. I think personally, I would stick with the Public Health England / government advice about shielding. You may get different opinions from different doctors, but they are no more expert than I am, or we are, or any of us are, and they may have an opinion, but given the uncertainty, I would stick with the shielding for 3 months. Nigel mentioned before what happens if this goes on for longer. Maybe we'll get into that discussion, Zach, shortly, but I think for now, for May, June, July, or May, June at least, I would just simply stick with the PHE advice, regardless of what any other healthcare provider might advise you. But that's my view.
That's probably a good segue into, because we've had the last two of the last questions I've had in are, so someone saying their shielding letter said 12 weeks, this ends in the middle of June. What should they be doing? And someone else asking, what happens if shielding is recommended for something like a 12-month period? Is it realistic to expect people to follow such stringent measures for this long period? So I think, should we flip it this time and let's see what Nigel's perspective is to someone living in this situation, and then we'll see what yours is, Steve, on this clinically.
Yeah, I think obviously it is an important question because it's one that we were chatting about before we went live about this. You know, the TV last night and the guidance were basically saying this is going to be with us for 12 months before there is a vaccine, etc., potentially longer. Therefore, in theory, that shielding should continue for that time period. That's, I think, unrealistic for most patients to live a life trapped inside for 12 months. So I think that people may move gradually towards the going out a little bit, but trying to avoid people. Go out early, go out late, wear a mask if that is what makes you feel happier or that becomes the guidance. But ultimately, if this goes on a prolonged period of time, I think shielding in that sense becomes very, very difficult. So that's the first thing. The second thing I would also ask Steve to sort of comment on is the NCI guidance. Obviously is a little bit different than that which we're talking about today. And what your view is on that. I think your view is probably belt and braces, better to be safe than sorry. But yeah, so the two questions, the 12 months and the NCRI, please.
So, you know, people have asked me, what would you do if you had CML? I mean, I think I've made my position clear. For 3 months, I would absolutely shield. I mean, 3 months is a relatively small part of your life. Yeah. And it might be over the top in terms of risk avoidance, but for 3 months, you can probably live with it. Could I live with it if it was 12 months? I think I'd go around the twist, really, if someone asked me to completely shield and just be stuck in my house. Whether there'd be divorce proceedings or grievous injury to my children would have to be considered, given the way they are. But you know, I don't know if I could do that, and I don't know if it's a reasonable thing to ask CML patients to do for 12 months. So don't know the answer. I think we'll have to wait and see what comes out. But I think society generally, businesses, economy, mental health, normal functioning is going to have to decide on a tipping point sometime in the next few months between keeping us all locked down and shielded for some people versus getting back to some sort of normality. And I don't think any of us know what that's going to look like. But I think beyond 3 months, it becomes more problematic and more difficult. And I think some compromise is going to have to be reached. What that is, I don't know. Nigel mentions the Nci Guidance, which is on the British Society of Haematology website. I think colleagues were trying to sum up clinical views on what they felt was the risk to CML patients plus or minus TKIs. And I think, again, it's uncertain. Do I see lots of patients with major immune compromised problems in my clinic on TKIs? No, I don't. So, you know, if it gets past 3 months and you're as fit as a fiddle with your CML, you've had no problems at all, could you be a bit less stringent at that point? Maybe. But again, coming back to my original point, I'm not an expert on the epidemiology of COVID. We're all learning, and I'm uncertain about that. So I think cross that bridge when it comes to it. But yes, I'm conscious there's a slight conflict in the advice that's out on the internet there. And again, I think you have to use some common sense, take the information on board and choose whether you want to be completely conservative or less so. We're all grown up, so we can all assimilate this information. But my position, certainly for 3 months, is just to stick with the shielding. After that, I think we might have to think about it a bit more carefully.
And just to specifically comment on the NCRI guidance from the numerous different haematologists that we have spoken to who were involved in the drafting of it, I'm yet to find anyone who was involved in the drafting of it who doesn't recommend shielding. So the guidance is, I'll say this rather than anyone else, the guidance is slightly unclear in that it says at the moment we have no evidence that CML patients are at any higher risk than the general population, and it doesn't mention the word shielding, but the guidance is follow the government guidance. So anyone who's seen the NCRI guidance and thinks that means don't shield, it does not. That is not the message that we are hearing from those who were involved in the authorship of it. So one specific question we've got as a follow-up to that that's come through the chat is where people have heard from their haematologist that the NCRI guidance tells them they don't need to be shielding and therefore they're not registering them as highly vulnerable. What is the position in terms of what they should be doing as they have not received a letter?
Well, I guess you're going to know my answer to that, Zach. I think the PHE guidance, Public Health England government guidance, trumps anything else, to use that unfortunate word. And therefore, I think they should be registered. They should have access to the services that people who are shielding might expect, or the provisions for them. Whether or not they've had a letter, which we touched on before. So I think let's keep it simple. PHE guidance is pretty clear about this, and I think we should stick with that.
So
I've not received a letter, and it does frustrate me that they're coming out. It does seem to be so hit and miss about who gets one, who doesn't get one, and so on. But I think, you know, just to reiterate what you've already said, shield if at all possible, or as much as you possibly can.
So one of the questions that we're getting quite a few questions actually in relation to this, is family members. So if you as a patient are shielding and you're living at home with other family members or anyone else who lives in your household for that matter, should they also be shielding? The government guidance is that if they can socially distance from you within the house, then they don't need to. But how practical is that for some people, and what should you be doing in a situation where it's not practical?
Well, if I think of my house at the moment, if my wife was shielding, what would I do? You know, I kind of have to come to work and look after patients and do my on call and stuff like that. I have to go and get food. The dog needs a walk now and again. I think this is at the limits of what you can actually force people or oblige people or suggest to people to do. So the key person who's shielding should stick with all of those behaviors you described at the beginning, Zach. But I think if you're living with someone who's shielding, you just have to do your best. You've got to go and get food. you've got to go do some of the functions of normal life. But I think within the home, keeping your distance and paying scrupulous attention to hygiene is going to be the best that most people can achieve. I think strict shielding of a family member means that nobody ever leaves the house, and that's just not going to work if you want to carry on some kind of normal function and managing to eat.
Yeah, I mean, the reality of day-to-day life is that if you live in a normal home, the person who's going out to work or the children are interacting with other people, they will, no matter how much they try and keep to the guidelines and clean, etc., there will be slips of that. It becomes a very, very difficult thing. You've just got to do as much as you possibly can. But ultimately, if you're sharing a home, you're sharing a kettle, you're sharing a toilet, you're sharing a this, that, and the other, to keep 2 meters apart and never touch anything that somebody else has touched is just not going to happen realistically. We've just got to be as good as we can and keep hygiene to its best.
So how would your guidance change if the person who you're living with is experiencing potential symptoms of COVID? Obviously not been tested, but if they've got symptoms and you're living with them, how should you be reacting as a CML patient?
That's a tricky one, isn't it? Logically, if you are shielding and you are at risk and a family member who's right in your house has the symptoms that would really fit for it, you want to be out of that situation, really. Now, again, what would I do if that was in my house? I think I'd probably, I don't know, I'd maybe come and live in NHS accommodation somewhere, but not everyone has that access. Could I go and stay with another relative to protect my loved one who is shielding? I'm not sure I have the answers for that in every situation, Zach, at all, but particularly if someone is symptomatic, then I think you really need to keep away from them. And Nigel mentioned the kettle before, the bathroom, what have you. I'm going to be getting the alcohol wipes out or the hand sanitizer and going nuts with it. And all of those things you've heard so many times about, sneeze, but throw the tissue away, wash your hands with soap scrupulously. Again, it's constrained by the limits of the realities of life, but I would be particularly concerned to try and keep well away from someone who's symptomatic.
So
can I just mention on the washing your hands scrupulously? It's very interesting. I saw or read an article recently about why that is so important, and the fact that because the virus is basically broken down by soap, it is the best way of actually getting rid of it. And just to really clarify that, because I think a lot of people don't realise why you're washing your hands. It is obviously for the cleanliness, but it's to break down the virus on the hand, because the cell membrane is broken by soap. And I think it's just useful to know the reason why that's actually happening rather than just do it because you should do it.
Yeah, I think that's exactly right, Nigel. And again, at home at the moment, we're all just washing our hands loads and loads. I mean, consciously much more than you would normally. And using one of those pump soap things, but you're absolutely right. Soap is critical. It's cheap, it's easy, and it will destroy the lipid coat of the virus. So simple but a very important measure.
And it doesn't need to be antibacterial as such. It just needs to be soap.
Exactly.
So we're getting questions in from people who are worried that what decisions are being made in terms of prioritization of treatment, whether certain people are going to get ventilators, whether certain people are not going to get ventilators if they do contract COVID, and also people who've been asked if they go to hospital whether or not they want to be resuscitated. So they're worried about the prioritization as a cancer patient. What can you say to that, Steve?
So I feel fairly strongly about this, and I think the government has clarified this a bit recently. I mean, there was some discussion in our hospital maybe a month ago to say, if there's a huge wave of patients and we haven't got enough ventilators, and unfortunately we're not in that position. We do have plenty of ventilators and plenty of beds at the moment, so we've not been overwhelmed. But there was discussion to say basically anyone with cancer is not going to get ventilated, and clearly all cancers are very different. If you've got metastatic terminal lung cancer, you're very different to someone who's had CML, has been effectively treated and is off treatment. The prognosis for those two individuals is hugely different. And I think now a bit more compassion and common sense has prevailed in things I've heard and seen, in that there isn't a blanket approach to who gets ventilated or not. There is an individual discussion about patients' risk factors, their prognosis, etc. And particularly for CML patients, because the survival with CML is essentially normal now with modern therapies, I absolutely think that just having CML should not exclude people from considerations of ventilation if they should require that. If they have other illnesses, if you're elderly with 3 other medical problems, then yes, that might influence a decision. But I think that's independent of whether you have CML. So I would feel very strongly that a patient with CML who's very ill with COVID should be given the same chance as the person next to them of the same age with the same other comorbidities, etc. I don't think CML carries such a poor prognosis that ventilation should be considered. The opposite is true. It carries an excellent prognosis these days.
But as a patient, and hearing that and knowing that, I mean, I've actually made some notes so that if I actually went into hospital to actually try and give to a doctor or a nurse to give an explanation about what CML actually means, on great copious amounts of stuff, and the reason why potentially I should be ventilated, because it is a worry to a lot of patients, this. And I think it's all well and good you knowing that as a professor with CML, but your average doctor, I don't mean that disrespectfully, or nurse when they go into the hospital, this person has got leukemia, therefore should they be treated? Now, is there something the NCRI or yourself or somebody could put out that actually gives clarification of the fact that our prognosis is very good, to enable us to potentially, if ever that was needed, be available, that we can actually say, look, read this, this is coming from the NCRI, this is coming from Professor, whatever the case may be, to give us a better chance, because best in the world, if I'm the patient and I'm critically ill, I'm probably not going to be in the position to have that argument. It's probably going to be my family that need to have that, and they're probably not going to have the knowledge that I'm going to have.
I think the most important thing, Nigel, if anyone on the call is faced with that position, i.e. they have CML and they get COVID and they're looking at a ventilator, it's crucially important to involve the local haematologist and get your family to say, ring the haematologist and speak to them about this. And that's probably more useful than a guideline somewhere on the internet that nobody will ever look at or pick up in an acute situation. And it's very different. I mean, sadly, I had an older gentleman with acute lymphoblastic leukemia a couple of weeks ago who was very sick, even before we had any chemotherapy. With him, because that prognosis was very poor and he had other illnesses, he had non-invasive ventilation but didn't go on a ventilator, and that was with his consent, with discussion with his family, etc., and it was probably the right thing to do. But that's a world apart from having chronic myeloid leukemia. And you're right, Nigel, some people who are not expert in this area will just take the word leukemia to mean the same for everything, but clearly it's not. Some leukemias are very innocuous. There's been concern raised about chronic lymphocytic leukemia, for example, and others where the prognosis is very good. So I think critically, you or your family member need to make sure that the COVID team looking after you, if you get into that position, rings the haematologist and has a discussion with them.
I think that's the point I'm really trying to get at, is fight your corner for other patients who are watching this, if it happens, and I'm sure everyone will, but it's making sure you or your family ensure that happens, basically.
Yeah.
So we're getting some questions in relation to vaccines. The first one is in relation to trials, whether CML patients should consider being part of vaccine trials.
Two thoughts on that, really. I think, firstly, commonly in protocols for investigative new medicines, having other significant illnesses would exclude you from participation. So I don't know, because I've not seen any of these protocols for vaccines, but I think you're probably not allowed to participate unless you were completely fit and healthy with no other medical conditions, and having CML would probably exclude you. Point two, given all of the uncertainties we're discussing, not least of which is the efficacy of any vaccine, but also the potential side effects of vaccines as dose escalations are performed, etc. I think if I had CML, I wouldn't be going into an early vaccine trial program. The opposite might be true once the efficacy and the safety was established, and that might take, who knows, 6, 12, 18 months, we're hearing. And if there is some susceptibility for CML patients, then maybe those patients should be getting a vaccine once it's proven. But that's way down the track. So, we talk about flu vaccines, pneumovax, etc., for many of our patients who have slightly weakened immune systems. But I think that's when it's established. But simple answer to your question, Zach, is A, I think you'd probably be excluded, and B, I don't think it's necessarily wise for the early phase trials for patients with leukemia to be going into them.
And a second question, which again I think I know the answer to, but if the vaccines are developed successfully, is there any suggestion as to whether they will work against CML for CML patients?
Tricky again. Honest answer, I don't know. Slightly more scientific answer, there have been some studies done looking at the immune responses that patients with CML mount when they have had more established vaccines. And there's some evidence there that if you give patients with CML standard vaccines, they don't mount such a good immune response as patients without CML. But the numbers are small. There are a few of those studies. And of course, there's no such study with a coronavirus vaccine as yet. So maybe in a year we might know the answer to that a little bit, Zach, but at the moment, I think, don't know.
So again, another question that we know the answer to, but I think we should say it again, just to be really, really clear. Someone who's saying they've been in TFR for 11 years, are they still considered highly clinically vulnerable?
I'm going to stick with my position on this and the PHE guidance. It might be over the top, but if you read the guidance and you presented at the beginning, and then such an individual would be considered to be highly vulnerable and should shield. And as we've said, Zach, that might be over the top, but I think for 3 months, that's probably a smart thing to do. After 3 months, given all the things we've discussed, such an individual may be considered to be less at risk than someone who's had a bone marrow transplant 3 months ago, for example. So there might be some more nuance then, but I think for the next couple of months, we should stick with the simple party line, and everyone with CML should shield.
And I think just to be clear as well, so the government guidance is obviously you should shield, but that, as you've said a couple of times, it's a decision for people to take if they decide not to shield. If against advice someone decides not to shield, what would you say in terms of trying to minimize the risks alongside that? How practically can they do that if they aren't shielding?
It's all the things that we've been discussing a little bit. It's simply trying to avoid contact with anyone who has or may have this virus. So all of the lockdown measures, the normal lockdown measures, if you like, that we're all being asked to do, social distancing, minimize your contact with other people. That's what's involved. So I guess you're going from shielding to standard lockdown. Don't leave your home unless you have to. Don't travel. Minimize trips to the shops, etc. But again, to emphasize, and you won't be surprised to hear me say this, Zach, I think that's unwise. I think for the sake of a few months, you should be as strict about this as you can at the moment, pending further developments. Nigel, I don't know if you have a view.
I agree with what you just said there. Basically, I think that is the right advice to follow for the moment. Obviously, as we discussed 20 minutes ago, as time progresses and we go into 6 months, 12 months, then I think naturally that will change people's perception. I think you can actually see that out in the streets a little bit more. As I say, I do go out occasionally, and I do feel that people are starting to venture out a little bit more, whether it's the good weather or whatever. And I think the longer this progresses, people will become a little bit more bold, unless they start knowing people personally that have been affected by it. And I think that will change people's perspective. whilst they don't know people who've been affected by it personally, I think there can be a little bit of, it's not going to touch me, and we need to be careful we don't get apathetic, I think is what I would say.
We've had another question in here in relation to employment, which I'm not going to put to either of you, don't worry, but I think we should raise it. So for those who are shielding and have not been furloughed by their employer, which the government guidance says that you can do, you can furlough someone who is shielding. People are asking what they can and can't do. We can't really answer that on the webinar, but the one thing I would say is Leukemia Care do have an advocacy team. Leukemia Care do have a specialist welfare advisor. So do feel free to get in contact with Leukemia Care either via the helpline or by emailing advocacy@leukemiacare.org.uk. We can't answer individual circumstances here on the webinar, but they will be able to help you and support you in conversations that you're having with your employer to explain what the government guidance is, the fact you are shielding, and that you can be furloughed. So I apologise to any colleagues who are now going to be overwhelmed with requests, but do feel free to get in touch with the Leukemia Care team. And secondly, I would say, obviously, if you have individual questions, either clinically or your personal situation, the first thing to do is to go to your healthcare team, same as normal. But also, if you have any questions or comments, Leukemia Care are still here. Our services are still running. We're still running our helplines. We're still running virtual support groups. We're running things like these webinars. We have all of our staff are still working from home. So do feel free to get in touch with us in the normal way. Things have been busy over the last few weeks with queries, as I'm sure you can imagine, but they're starting to get back to normal. So please do keep ringing. Please, if you have questions, feel free to get in touch as you would do in the normal way. So we're running nearly out of time. Have you got any final comments, Steve or Nigel, you want to say?
The one thing I would just add, and something again we touched on yesterday, and it's not related to CML, but there was a big news article last night basically saying that cancer admissions or diagnoses are down by about 80% currently. And whilst I'm sure it's not going to affect, I hope it doesn't affect anyone here, but if you have family members that are unwell, get them to go to the doctors, get them to go to the hospital, because ultimately all of us at one point were not well and took the step to go to hospital, be checked out. And there is a real fear that whatever illness, not just cancer, could get missed by people shielding. So again, obviously we have to be sensible, but just bear in mind a clinical need.
And just to echo that, we're in pretty much constant conversation with NHS England and with all of the cancer leads there. That is their guidance. Their guidance is for other people, continue attend cancer screening appointments where they're going ahead. And if you're worried about symptoms that may be cancer, then they should be going to do so. Again, that is, the data's not really there yet to see how much it's falling, but people are worried about things like CML not being picked up because people are not going and visiting and getting a blood test where they're worried about these symptoms. Any comments from you, Steve?
I think I'd agree with that. We were talking before the call went live about, our cancer unit is actually fairly quiet because we're not doing some elective treatments that we would do. But I think Nigel's point is right. There are probably people who have symptoms there who would, in other circumstances, have gone to the doctor and may turn out to have cancer who are not doing that. So maybe not a direct CML message, but certainly a message to be aware of for other friends, family members, colleagues, etc. That it could be business as usual in that respect. If you have significant symptoms, don't ignore them.
Well, so two final things from me. One, we've been very busy with the questions coming in the various different platforms. So apologies to anyone if we haven't managed to answer your question. And secondly, we're getting now the overwhelming thank yous coming through on the different chats. So thank you from me to Steve and Nigel for giving up your time. As we've probably all seen with Steve's constant notifications coming through, he is extremely busy right now. So thank you for giving an hour of your time to answer all these questions coming through from people. We'll look to do something similar probably in 2 or 3 weeks' time for different leukemia types and also hopefully for something else in CML. So do keep tuned as to what's going on and how the situation is changing. But in the meantime, you've heard the advice. The government guidance is clear. I'm not going to make Steve say it again for about the 15th time, but you know what the answer is as to whether or not you should be shielding. Thank you very much, everyone.
Can I just say, given that we've talked about 3 months of shielding, maybe another CML related webinar in a month or two, when we will know whether or not we're being asked to extend this period of 12 months, could be helpful for people. We may not know all the answers, but just airing some of the points we've discussed today a bit further down the track could be useful. Maybe we should revisit that in a couple of months.
Yeah, exactly. That's what we're looking to do. And if that's something people are interested in, then let us know. And we're happy to do another one.
Thanks, Zach.
Thank you.
Thank you very much, everyone.
Okay, cheerio.
All the best.
Take
Bye-bye.
care. Bye.